Our next speaker is a registered dietitian who's conducting her PhD at the University of Coventry in behavioural science and having direct experience of food addiction herself and maintaining her own 150-pound weight loss. She's also the operations manager for Liberate, our food addiction coaching course from us, the Public Health Collaboration. Please welcome to the stage, Ellen Bennett.
That's so bizarre, hearing my weight loss in pounds. Can everybody hear me okay? Yes. Excellent. Okay, so I am Ellen Bennett. I am a registered dietitian and affiliated with Coventry University. And when my daughter heard that David Unwin's lizard was getting centre stage, she was like, why can't our tortoise have centre stage? Let's get Buttercup involved. I thought, how are we going to do this? And, without my daughter letting me work, Liberate wouldn't be able to be possible, so I'm going to do that for her. So I sat with Buttercup for a while, and it turns out she has a lot of sage advice, which I will give you at the end. So I am thrilled to be sharing the findings of the feasibility and acceptability study that we started in February last year. If you were at the conference last year, you'd have heard my background story and you'd have heard the post results. This year, we'll be able to present you the 6-month follow-up results. So conflicts of interest, this research comes as part of my doctoral award. The stipends and fees have been covered by Coventry University, and I'm employed as the operations manager for Liberate by the PHC. So, food addiction. I don't know how to use this, sorry. I'm going to use this. Food addiction, and more recently, as the consensus has brought together to term it ultra-processed food addiction, has been discussed in scientific circles for over 6 decades, but it is still absent from the DSM-5. There is growing evidence support that the idea of behavioural patterns that we see in ultra-processed food addictions mimic those of substance use disorder. From a biological and psychological standpoint, the overlap is actually quite striking. And ultra-processed foods are engineered to be hyper-palatable. We want to go back for more. That's the idea behind them. Some researchers have also suggested they may be more addictive than substances like nicotine or cocaine. And why is this important? It's because if we treat ultra-processed food addiction as merely a lack of willpower, we might be missing those deeper drivers. And more importantly, we'll miss the opportunity to intervene effectively. So globally, between 14 and 20% of adults may be living with ultra-processed food addiction. And we have validated tools such as the Yale Food Addiction Scale and screening tools such as CRAVE to be able to help us identify people in our clinical practice that we could offer additional support to. The challenge remains that ultra-processed food addiction often overlaps with, but isn't identical to, things like binge eating disorder. It isn't just a matter of somebody's overweight, then they must be food addicted. It's not the case at all, which is also difficult because that's how we associate it. We use a weight-centric lens to be able to say, okay, maybe that person's food addicted, but it's not always the case. But there is a clear call for targeted interventions, but as of now, very few exist, and that's the gap that we wanted to try and fill with Liberate. So, for our study, we had our research aims and objectives to assess the feasibility of delivering an online community-based intervention for those with ultra-processed food addiction, to evaluate participant acceptability using both quantitative and qualitative measures, to measure changes in food addiction severity, well-being and anthropometric data, and finally lay the groundwork for future randomised controlled trials exploring effect sizes. So this was a mixed method, single group, pre-post feasibility study with a nested qualitative component to explore acceptability. We recruited 105 participants for an online intervention, which we called Liberate, and it ran over 6 weeks at the time with 8 sessions and was followed up with a year's worth of optional peer support, also conducted online. We used validated measures, including the YFAS, Craved, Binge Eating Scale, and when Webb's, the Warwick Edinburgh Mental Wellbeing Scale. To ensure rigour, we used an intention to treat analysis, so all baseline data were carried forward if the participants didn't complete the follow-up surveys. For the qualitative side, we used the theoretical framework of acceptability, which I'll touch on in more detail shortly. So a bit more about Liberate. It's a coach-led community-based online programme built specifically for people struggling with ultra-processed food addiction. It's a psychoeducational course and it supports both abstinence-based and harm reduction approaches. Importantly, we do promote the low carbohydrate dietary foundation, although this is very personalised to the individual. In each weekly session, it lasted about 90 minutes and included education around the neuroscience of addiction. This is really important. A lot of people, they just think it's their fault. They don't realise the brain changes that they've experienced, and that I often hear, why can't I just do it? I know it, why can't I just do it? And once they've learnt this, there's a sense of relief, and then the healing can start once they've learnt that it's not their fault. So it's important that that stays in. We give them practical food strategies, and again, the other part that's very important is that peer support. In addiction medicine, the peer support is crucial, especially from people with those addictions as well. They tend to do a lot better with their recovery. So we place strong emphasis on psychological resilience and long-term lifestyle changes, not quick fixes. This is not a quick fix at all. Recovery is lifelong. It gets easier, but it's always there. It's always there in the back of your mind. So our results. In terms of feasibility, we managed to recruit 105 people, just short of our target of 135. Of those 105, 86 started the programme and 59 completed the 6-month follow-up. That gave us an overall retention of 69%, which is better than the national diabetes programme. So what we learned is that people liked it, they wanted to keep coming back. So that was a pro for it, for sure. It's a community-delivered voluntary programme, especially online. These are strong retention figures. So let's have a look at what changed for our participants. Let's start with the food addiction scores using YFAS. So at baseline, 70% of the participants met the criteria for severe food addiction, and that dropped to 26%. So some of the people at the end of the 6 weeks and at follow-up wouldn't have even made the cut to be able to come on to Liberate at that point. So that's how much it dropped, and it stayed there, 34% at 6 months. Meanwhile, those showing no food addiction rose from 22% to 69%, which is a big change as well. Mental well-being also improved. We needed a 3-point change on the Webb's scale for a community study, and we achieved 6 points. So it was good because we wanted to make sure that maybe they were losing their food addiction symptoms, but they were generally unhappy afterwards. That would be no good. I wouldn't like that. But we actually found that their well-being went up. This isn't a randomised trial, but the outcomes do show a clear promise. And more importantly, sustained those 6 months later on, whether they came to the follow-up, the weekly support groups or not. So we also did qualitative part to this study to make sure we learned in more depth what worked and what felt acceptable to them. Under the theoretical framework of acceptability domains, affective attitude participants felt validated, understood and empowered, often for the first time. And some of these participants had been doing this for 5 decades, in and out of commercial diets and in and out of GP offices and things like this. So there was a sense of relief. So I kind of tell whether or not I've done a good job if the first time I meet somebody they start crying. But it really is a crying of relief, like they've finally been heard. So there was a lot of that. And burden, for the other domain, is the programme. They overall found that the programme was manageable overall, and some people describe the workbook as being a bit demanding, particularly when juggling other work life and family life, but it became a habit over time, and then it wasn't so burdensome. And there was a clear sense as well that they really had to want to do it. They've got to be in that right mind, ready to do it as well. They wanted to put that effort in. Under ethicality, they liked the fact that it was non-judgmental. It came up a lot that it was delivered by people that had that lived experience, which we see again in addiction medicine as well, where other drug and alcohol addictions, when it's delivered by somebody that's had recovery in drug or alcohol use, they tend to do better. So they felt they weren't judged. People had been there before. They enjoyed the evidence base of it, so we bring the science in and we show them where the evidence comes from for that and why these techniques work. And they really appreciated that it wasn't about shame or blame. So there was a lot of people saying that they would always feel shame after going back to the GPs to be weighed again, but they felt empowered to be able to go to their GP in the future and go, I'll stand on the scales, but I don't want to know the results. I don't need to know that today. With some people even standing on the scales backwards so that they don't have to address that today and the doctor can do what they need to do with it. Intervention coherence. Participants found the content clear, well-paced and pitched at the right level with a good balance of science and practical advice. They really enjoyed the options of the videos that we sent them afterwards to really enhance their learning as well, so they could take that at their own time. So they enjoyed that as well. When it came to opportunity costs, some people struggled initially with the cost and the effort of changing their diet. So at the beginning, the cost of food, they tend to eat a little bit more until those hunger levels level out, and then they stop eating as much. But what they did realise is that they weren't buying as much as their drug foods, their ultra-processed foods, and the effects was rippling into their families' foods as well. So the participants were getting good effects, but so was the family as it was rippling out to what they were eating. So the costs did balance out in the end. Perceived effectiveness, many described the increased self-awareness, reduced cravings and stronger impulse control. In their words, and this came up a few times, which was lovely, they said it was life-changing. I've heard that again already this morning, which it just makes me want to keep doing it for sure. Self-efficacy, crucially participants left feeling more confident that they could manage their addiction in the long time. There was an extra theme that came up during the qualitative analysis outside of the domains, and that was about how, it was quite a strong one that we've put it in as part of the write-up, is that there was a strong call that they would have liked to have known this from their GPs sooner. Even if they didn't do anything with it at that point, have that seed planted and know where to go. We saw growing calls for the integration of these sorts of interventions within the NHS. And another strong theme was that they wanted to feel that their GP would take this seriously. Often people with food addiction feel like they're not being taken seriously. So that was a strong theme as well. So what do these actually mean? First of all, feasibility has been clearly demonstrated. We successfully recruited, retained and engaged participants in an online community-based programme for ultra-processed addiction. The second is the quantitative data shows significant improvements in both food addiction severity, mental well-being, and sustained over the 6 months. And that's promising, especially given this was only a short intervention. And thirdly, the qualitative feedback affirmed that Liberate was acceptable, empowering, and gave people tools that they could actually use in their daily lives. Participants also highlighted how vital ongoing peer support was crucial for their recovery. When we look at this in the context of broader literature, our findings align with the existing researches on the mechanisms of food addiction and the potential for dietary interventions. But this is the first UK-based feasibility study of this kind delivered entirely online. Ultimately, these results support the argument for classifying ultra-processed food addiction under the umbrella of substance use disorders. I would love to see that happen in my career lifetime. I really keep going with that, Jen, definitely. And more importantly, for treating ultra-processed food addiction with the same seriousness that we do with alcohol and drug addiction. So, like any study, ours has strengths and limitations. This is one of the strengths. It's the first UK feasibility study. We used a mixed methods design, giving us both breadth and depth. We applied the intention to treat analysis, which strengthens the credibility of the quantitative findings. We had a strong retention, which is not easy to achieve when it's voluntary and it's online. But there are the limitations. It's a single group, non-randomised design, so we can't attribute causality. The intervention was relatively short, and while we saw sustained outcomes at 6 months, I would like to know long-term effects, and they need to be explored as well. We didn't include a control group, so we don't know how this compares to other interventions or no interventions at all. So what do we need to do next? Well, we need to do a randomised controlled trial to test causal effects and refine the model. There is also a need to explore the neurobiological mechanisms and dietary pathways involved in recovery. And most of all, we need to integrate ultra-processed interventions into mainstream public health services so people aren't left unsupported. And for anybody out there that works clinically or works with clients, if you wanted to start integrating food addiction or even trying to bring up the conversation, I would just start by planting that seed and suggesting a quick screening tool using Jen and Heidi's craved questions. 6 questions, all they've got to do is answer yes or no. It's not going to take a lot of your time. And then you'll be able to start signposting them to that extra support. We're currently writing a perspective piece with Dr. David Unwin aimed at those with type 2 diabetes and ultra-processed food addiction. In that document, there's going to be a list of recommendations, so that will give you a leg up, if you like, to start using that in your clinical practice and help you to support your patients with ultra-processed food addiction. So do look out for that when it comes out. So this study shows that Liberate is a structured online intervention for ultra-processed food addiction. It's both feasible and acceptable. It showed early promise in reducing addictive food behaviours and improving participants' mental well-being. It's not the final answer, but it is the starting point, and it's one that supports a case for larger trials. It's a long overdue conversation of how we recognise and respond to ultra-processed food addiction. At this point, I'd really want to say a big thank you to the public health collaboration, huge one. This would be sitting on my desktop wondering how on earth do I get this out to people. So I'm really grateful that you've been able to support that and put that out there. We've helped over 150 people so far, and many more are on the way. But I wanted to say, and I don't know if she's in the room, and she probably wouldn't like it anyway, but I wanted to say a big thank you to Sarah James, our PHC operations manager. She's probably the only one that can understand the amount of data that we've had to sift through, and without her IT skills, I think I'd still be under it all. And of course, a big thank you to the study participants, because again, without you lot, this wouldn't have happened. And it's so brave and courageous of you to be able to come out and share the things that you have done with me. And you didn't even know me, so well done for being so generous and honest and sharing your experiences. And of course, the research team and funders and anybody that's engaged with the conversation of ultra-processed food addiction, because we've got to keep that momentum going. If you'd like to know more, you can contact me through the email. You can come and catch me as well. Those in Liberate, grab your badges. They're on the table in the corner over there. But let's have a look. What does Buttercup have to say about ultra-processed food addiction? The lovely Buttercup. If you ever do the course, every now and again she just wanders in my living room floor, and just, she's like a bulldozer, actually. They're faster than you think. So what does she have to say about addiction recovery and how she lives her life? Well, she was saying to me, she's tough on the outside, but vulnerable on the inside. And this is the same for recovery. Buttercup's developed a hard shell to protect what's soft and wounded and sensitive underneath. In early recovery for the addict, that shell is essential. Over time, as we heal, we learn to be vulnerable again, but it takes courage to start cracking that shell and start opening up. So if you're in recovery and you feel like you're isolating, it's okay. Keep going. Eventually, you'll get stronger. Buttercup carries her home on her back, just like we carry our recovery wherever we go. It's a sense of internal safety, and that takes real work, learning to feel safe in yourself no matter what life throws at you, and not leading toward the food to make it all feel better. And let me tell you, that does not happen overnight. It's a long journey. Buttercup, she withdraws when threatened or triggered. As an addict, we might recover, especially in early recovery, we might pull back when their friends start suggesting a bottomless brunch. It's not because we're boring or antisocial, it's because we're protecting our peace, guarding our recovery, and that's wisdom, not weakness. She's protected, but she's not invincible. Her shell has limits, and so does our recovery, and this is why we create boundaries. They may seem drastic, especially at the beginning, to those that have known us whilst we're in active addiction, but these routines and these structures, they're not rigid, they're reinforcement. So if you're supporting somebody with ultra-processed food addiction or any other kind of addictions and they start creating these boundaries, support them with that. She's resilient even when reclusive. Sometimes you won't see much of us, especially in early recovery. This doesn't mean we're stuck or we're suffering, but like the tortoise, we're quietly moving forward, learning and healing, and sometimes the biggest breakthroughs happen in solitude. Buttercup always looks grumpy. So do many of us in the beginning of early recovery, because it's not fair. They get to eat cake, why can't I eat cake? Well, so we can sometimes look a bit recovery. At that point, when this happens, I do check in with people and make sure that they're eating enough protein and enough fat, and make sure that they're having their electrolytes. And if all of that's covered and you feel grumpy, just be grumpy, let it out, and just let it go. And if you're tired, just go to bed. There's a lot of healing going on, especially in early recovery. Her shell is not her shame, it's her survival. Just like our past, the scars we carry are not signs of failure, they're proof that we made it. The shell is part of the story and it deserves honour, not judgment. I wish I'd known this in my early recovery. It was Jen that got me to start talking about my story, because I wore my story like shame. I didn't honour it, and I do now. It's made a big difference. Slow and steady wins the race. Tortoises, and especially buttercups, they don't do quick fixes, and neither do we, not anymore. Before recovery, we tried them all, the crash diets, the resolutions, the guilt-fueled restrictions. We did it again and again and again. But in recovery, we've stopped sprinting. We've started walking. Every step we take now is deliberate, grounded, and conscious. That's the pace that we're working with. Tortoise live for a long time, and so does recovery. It's not something you do for a few weeks, it's a lifelong journey. But here's the thing, over the time, you'll start to love it. You begin to take in the view that you've missed for many years. You'll find people that are also in recovery walking beside you and supporting you, and you'll stop yearning for that finish line. You can't rush a tortoise, and you can't rush recovery. No amount of guilt, shame, or self-criticism will ever make it go faster. Trust the process and be kind to yourself. And finally, Buttercup doesn't care what the hare thinks. You know the story. The hare, though, was probably fueled on gummy sweets, full sugar energy drinks, and probably hungover, whereas Buttercup had sleep, boundaries, and a stable blood sugar, and you know who wins that race. So from now on, let's be more like Buttercup. Thank you.
Don't worry.